Great. So the interest of time, I'm just going to remind everybody about the Q&A, which I'm hoping we'll have some time for. So put your questions in or raise your hand and we'll unmute you. And if you have any technical problems, you know how to contact Sidoni, who is invisible to you, but very available to you as you need. Also, importantly, the session is recorded and can be posted for you to view at another time. And it's just 2 minutes after the bottom of the hour in a very dark British Columbia. So I will just wait a few minutes while a few more people come. So yeah, great. So I want to acknowledge with humbleness and respect that I am an uninvited visitor, and we are hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and the Métis chartered community of the Lower Mainland region. Next slide. It gives me really great privilege and pleasure to be able to introduce Dr. Carolyn Tait. Dr. Tait holds a PhD in medical anthropology from McGill and is a professor in the Department of Psychiatry at the University of Saskatchewan. She's a member of the Métis Nation Saskatchewan and grew up in a small Métis community in central Saskatchewan, and is the nominated principal investigator of the CIHR-funded Saskatchewan First Nations and Métis Health Research Centre, and also the NEIHR National Coordinating and the Saskatchewan Indigenous Mentorship Network. So really an amazing presence she has in research, education, and furthering development. With Michael Moser, Dr. Tait established the Saskatchewan First Nations Métis organization, Organ Donation and Transplant Network, that's made up of knowledge keepers, persons with lived experience, researchers, physicians, and students. And for those of you that know our CanSolve CKD involvement, sounds a similar group of engaged and important stakeholders. So with that, Carolyn, I'll ask you to please proceed, and we'll look forward to having a good conversation. Thank you.
Okay, and I just, let me see here. I need to share my slides, and here we go, share my screen. I'm not the best tech person, I have to say. Slideshow. Okay, is that working okay?
Yes.
Okay, perfect. So thank you very much for inviting me. I have to say, I'm still getting used to online presentations, but I'm very happy to be here. I'm on Treaty 6 territory and the home of many, many Métis people in traditional territories of which I grew up with near Batoche, a little place called McDowell. I'm here representing a huge effort from a number of First Nations and Métis people in Saskatchewan through our Organ Donation and Transplantation Network, which I'll present. And I may go through the first part rather quickly to get to some of the issues, which I hope will spark some discussion. So yeah, so thank you very much for inviting me. I'm quite humbled by the invitation. And so I just want to talk a little bit about the Indigenous peoples of Canada, and that we are very distinct peoples, as you well know. And even within, I know British Columbia has many, many First Nations groups and also Métis people. And throughout Canada, that we have also really unique histories. So the time in which colonization occurred across the country for different groups and how it unfolded is actually quite different, depending where you're geographically located and which groups that you belong to. So for instance, when I grew up, I actually played hockey against girls who were in the Duck Lake Residential School. And my family, who were Métis, my father did not go to residential school. My grandfather didn't go to residential schools. And we were really left out. My mom and I were just talking about this in the 60 Scoop. We were lucky that we were left out of the 60 Scoop as well. And it had to do with the region that we lived in. that the social services was not looking at us. And instead, what the government did at that time is they had programs for Métis families. And that, so we were very, very fortunate that we weren't faced as a family with some of the policies and what happened to other Indigenous peoples, and we're recognized in the Canadian Constitution 3 distinct groups, and Saskatchewan is the traditional home of several First Nations and Métis groups, and I do this now anyway, and I'm sure you understand why more than ever after this week. But this is my Métis card, and so I'm a citizen of the Métis Nation. And so for anyone who works with me, I now show them that card so that they have confidence in who I am, that I say who I am. And so I just want to say a little bit about, to contextualize myself and the Métis and First Nations people of Saskatchewan, just through a little bit of family here. And I think what's so striking is identity in all of this, and who we are as a family, and which means many families are like us who are Métis. So the picture of the man with the boy with the very blonde hair, that's my dad and my brother Darren. And I love that picture because it really speaks to Métis identity and who we are. And then up in the corner is a picture of myself and my son, who is Skender Ben Boubaker, who is a Tunisian kid, Arab kid, who's also Métis. And that's him and his grandmother, that very little woman there, and some pictures of my grandmother and my father and my sister and I, and my mom with I'm not sure, I think that's my sister. And so as you can see, and my point is that the First Nations, Métis, and Inuit in Canada are a very diverse and complex group, as you can imagine. And I also want to talk about truth and reconciliation and contextualize today's talk. No other time has truth been more important than it is now. And with the what we're finding in Kamloops, what was discovered but known, and across the country, this is a very sad story. But I draw my attention, and I hope the other Indigenous people who are here today, will speak to this maybe later. But that's that. There can be as many policies and all kinds of agreements done at this macro level around truth and reconciliation, but it's really about the interaction of us together as colleagues, as Indigenous and non-Indigenous peoples that matters. And so our think tank, our approach to organ donation and transplantation was not only to fill a gap that existed, to bring Indigenous voices to the table, but also to build reconciliation from a micro level where we interact with our non-Indigenous colleagues who are experts, and some of them I believe are here today, like John Gill, Jag Gill, and some of the other folks that we've met from BC. But this is really important because for us, it's about relationships and building really strong relationships so people do understand more of the history of colonialism and why it's important that we have Indigenous voices at the table. I'm a social scientist. I'm a word warrior, as David Turner calls people like myself. We are social justice people who, so I'm not somebody that you would talk to about Indigenous knowledge. I feel very strongly that I have elders and others that I work with, but I do not have I'm not there yet in terms of my training and in terms of who I feel comfortable being. I am a student, not a teacher in that regard, but I am, I believe, a teacher in terms of pragmatic solidarity and social justice, and the idea that, we have to go further than just acknowledgement and witnessing of what is happening with Indigenous people to Indigenous people, that we need to have pragmatic solidarity, which means that you need to use your positions of power, and many of you are very powerful people, to walk with Indigenous people on a journey that is truth and reconciliation. And that begins with respectful relationships and moral courage. Cindy Blackstock's in the news, my colleague, and she's an amazing person. She's in the news right now. We're going to have a decision today coming down about whether the federal government is going to dispute the human rights that she's been working on. I think now it's 15 years. It's incredible. But she talks about moral courage, and that means your professional associations and organizations must support our Indigenous leaders at local, regional, provincial, and national levels. And that's something that you can do, a very pragmatic approach, to truth and reconciliation. This is our think tank here, our members. It hasn't changed much in 2 years. And it's just absolutely a wonderful group of people that make up what we call our think tank. And so there's 5 patient leaders, there's 8 First Nations and Métis elders and knowledge keepers, Dr. Moser, our transplant surgeon, Dr. Joanne Kopel, who's part of CanSolve, which is just an amazing network of researchers and Indigenous people and others, 3 university researchers, including myself, public health educator, from the Kidney Foundation, 3 health science graduate students, and our administrative lead, Rhonda Tyon. And this is a little bit of the journey. COVID really transformed us, and I'm going to talk about that more later. But we have met monthly. We've taken a couple breaks in the summer, but we've met monthly for 2 years now. And again, some of the people who are here today will have joined us and presented to our think tank and know quite a bit about our think tank. And so this is what it looked like. We meet at Station 20, which is right where my offices, our offices are down in the core neighborhoods of Saskatoon. And this is a meeting pre-COVID. And so the value of the think tank, so as you know, and you're all very busy people, is that we don't often have the luxury to think and to discuss and to really take a thoughtful approach to a complex health issue. And commonly with Indigenous peoples, we're thrown into hotel ballrooms and we're asked to, come up with solutions and ask questions within a day or two about very complex issues. And it's quite alienating, and it's really unclear whether there's value to that or not, beyond the networking value, right? So what we wanted to do was to do something quite different. And we wanted to create an ethical space of possibility, which comes out of the work of Willie Ermine. And that idea of creating a safe space to bring people together to discuss this very complex issue of end-stage organ failure and organ donation and transplantation. And within that, we know that First Nations and Métis people in Saskatchewan, where we were focused, have very diverse ideas about personhood and the body and spirituality and citizenship, their relationship with the healthcare system, the level of trust that they have in the healthcare system. And all of this varies within families and communities. And of course, very quickly within our work, questions of equity arose around equal access to transplantation, equal access to dialysis and other types of treatments. And then we started to learn about utility and the question of utility within organ donation and transplantation. And we're working very much on that issue right now about what is that relationship between decision-making around equity and utility when organs are allocated, and how that can impact differently First Nations and Métis people in our province and elsewhere. And so the think tank provides a way to examine complex health issues outside of health crisis. So you can argue that there is a health crisis around organ donation and transplantation and end-stage organ failure for our people, definitely. But what we're talking about is that there isn't an incident. This happens often in suicide cases of suicide where there's, say a cluster of suicides, and then they bring people together around this crisis to try to come up with direction on what to do next. And so we wanted to have something quite different. We wanted to be able to build relationships with one another. So the think tank members were chosen because they were people who were leaders in the community. They were knowledge keepers, elders, people who had a history of working with in the area of health. And so we were very selective as to who we chose, and most were in Saskatoon because we really didn't have a lot of money. And we do provide compensation for our think tank members because many of them are retired and many don't have really big pensions or anything. So we make sure, and it's really a pathway for micro and macro reconciliation. And what has happened is that it has snowballed, and suddenly we find that we have gained quite a bit of attention from some really amazing people, and people who come and present don't know this, but there's been so many times where the presenters come and presented and then they've left, and we're all either in person or online, and just kind of looking at one another and going, well, I'm anyway, I won't, but one of our elders, I forget what he said, but it's like this, we're surprised, right? That these very intelligent, smart people who are very important in this field would come to us and want to hear from us and want to learn from us. So we're very humbled by the response to our think tank, by our colleagues who work in this area. And but I think that, it really has highlighted that the need for First Nations and Métis, Inuit and Métis involvement in provincial, territorial, and national decision-making about organ donation and transplantation, and that we can achieve reconciliation. So there's so much talk about reconciliation that sometimes I think people feel that it's become a hollow truth, and reconciliation has become somehow hollow because there's no pragmatic what is it that we are getting out of it? What is it that's being reconciled? What is it, like, where is the truth telling and the reconciliation working together? So I don't know the answer to that on a bigger scale, but I do know in the context that we work, that reconciliation through the creation of a collective intelligence. And what we mean by that is that we talk a lot about the loss of culture during colonization, but part of that was that colonization disrupted collective intelligence, and it disrupted the ways in which we could, ways in which our people collectively within, whether it's First Nations, Inuit, or Métis, were able to collectively solve complex problems. So if you live on the prairies in Saskatchewan in minus 40-degree weather, at a time where there weren't all the luxuries that we have now, that you have to be pretty intelligent to be able to make that work. And so we know that there was this high level of collective intelligence that has continued, often underground in our country, by Indigenous peoples. And so we want to tap into that idea of how do we create that, and how do we create that then in concert with Western ways of knowing and being in this area of organ donation and transplantation. And so the goals of our network now at the moment for the upcoming year is to help to improve the ODT data collection. Our Indigenous leaders want distinctions-based data. They do not like the term Indigenous. Indigenous is not a category for research, for data collection. And there's all kinds of reasons for that I'll give some examples. But we want to advance distinct-based ODT research programs through partnerships with other teams, and we're currently doing that. We have a number of partnerships that have developed, and develop a public education strategy targeting First Nations and Métis peoples in the province. And we hope to do that through some video work and others. So we're moving, some of the think tank will be meeting in person, and we do continue, we're going to revamp what we're doing with more of a national online presence and meeting format. So we would alternate between the months. and that. So I just want to talk about the data. I'm just watching my time here. Around data collection and governance. So whenever you have a healthcare issue that relates to Indigenous peoples, whether it's First Nations, Métis, or Inuit, is that if there's no data, then it's almost like it doesn't exist. And so data is so important. And it's in our people since the 1990s, when you look at the efforts of particularly the First Nations and the late Seal Tournier, who was from Saskatchewan, and Seal was one of the champions of the OCAP principles and data sovereignty. And so anybody who's working with First Nations and Métis people needs to be very aware of the history of data sovereignty and the importance of Indigenous peoples not only being counted from a distinct based approach and data being collected, but also how does that relate to data sovereignty principles? And how do you meet those principles? So CIHR does have a Chapter 9. So anyone who has CIHR funding and works with Indigenous peoples needs to adhere to that. But when we look at end-stage organ failure and organ donation and transplantation, many of our Indigenous leaders are at other tables. They're at tables around HIV, cancer, diabetes, which does relate to this. But they have funding to sit at these larger tables. But at ODT tables, there isn't funding at the moment for Indigenous peoples to sit at those tables. So we're trying to change that so that because you can only sit at the tables if you have the human resources to have people dedicated to be at those in those conversations. And so that's one thing that we've been trying to advocate for. And so, but what's interesting around the data gaps is that now all of you who work in this area and us and our Indigenous leaders have no way of knowing the number of First Nations, Métis, or Inuit people living with end-stage organ failure and how many of these patients are on transplant lists, for instance. And additionally, data does not exist that tracks the number of First Nations, Métis, and Inuit patients who are being excluded from transplant wait lists and the reasons why they are excluded, the number who receive transplants annually, the number who die while waiting for a transplant, how many Indigenous patients miss the optimal window of time when a transplant is likely to be most successful, and the average number of years of post-transplant survival. So those are some of the things that we don't know. And unless we put in a distinctions-based approach to tracking Indigenous patients, then we really won't know that. And our leadership relies on data coming to them so they can argue for increased services and supports from federal and provincial and territorial governments. And so we know that the health inequities exist, and that we know that the progression of illnesses in many of our populations advances quicker than it does in other populations. And I just want to draw your attention to, this is Mike Moser, did an informal audit of the patients in Saskatchewan. And we know that upwards of 50% of the patients waiting for kidneys in Saskatchewan are First Nations or Métis. We know this mainly because of status, their status as First Nations status. So that can be looked at if you're looking, because that's recorded. We also look at postal codes and other things, but we think it might even be larger than that. And so there approximately 16% of the population are Indigenous in Saskatchewan. So this means in the context of Saskatchewan, and I would argue in other provinces that have high concentrations of Indigenous peoples, and that the East is a little bit different in Canada, but when we look at the West, particularly and into Ontario and Quebec, we're talking about large numbers of Indigenous people in those provinces, and we don't know, we don't have answers to the questions that I put forward. And so in Saskatchewan, identification of First Nations and Métis is not consistently recorded in clinical and hospital records. As I said, we can use postal codes. Saskatchewan has the highest concentration of Indigenous peoples anywhere in Canada, with 85% of the population. And in our north this is even higher than the far north, that we have this large concentration of Indigenous peoples in our north. And so postal codes, we can look at that. But the lack of data collection and analysis specifically to patient identity results in limited attention being paid to rates of end-stage organ failure and improvement. So I cannot emphasize how important it is, and our leadership is really interested in having much better data. And so we know that for equity, there's barriers and gaps in the lack of services in remote, rural, and northern communities, jurisdictional. So we had one person in our research that they were dealing with 12 different jurisdictions well, they called jurisdictions, but there was provincial, federal, there was hospital, the responsibility of the hospital, of the health authority. And so it was just this crazy negotiation. We know that the geographical challenges of just transportation. We know that patient, what we put in quotation, non-compliance, so people not being able to get to their appointments or not being able to comply with the workups that you need to be on a transplant list and to be considered. And we also know there's high levels of mistrust of the healthcare system, and overall issues of systemic racism in healthcare. And this is a very complex topic that I won't get into here. And then again, as I said, the lack of resources for our leadership to be at decision-making tables across the country. And so I'm just looking at my time here. So here's some of the things that we've been debating, and I'm raising these because I want you to understand why our debates can be different. And these are just really simple examples that some of you have been involved in at our tables. And so we had someone place on our Facebook page from Whitecap Dakota First Nation. A woman said, "I will be an organ donor if I can donate to other Indigenous people." So I think, so that meant, should we have an Indigenous organ registry? And so we brought this, Dr. Gill was at that meeting. We had an ethicist from the University of Toronto who was there. And so this was put to the think tank. And this is how our think tank works. It was put to the think tank that day. And we had two of our senior elders, knowledge keepers, who disagreed. And on the one hand, it was said that, no, we wouldn't want an Indigenous registry because we would not differentiate that way in gift giving, in our desire to give to other people, that we don't do that in our culture, that we give to everybody. If someone's in need, we will give. It doesn't matter if they're Indigenous or not. And another one of our elders said, wait just a minute, we're so disadvantaged in terms of, and we're overrepresented in needing kidneys and other organs, and we're disadvantaged. And so if an Indigenous registry meant that more of our people would get organs, then yes, we should have a registry. And so as you heard the debate unfold, it was clear that nobody really thought an Indigenous organ registry was a good idea. But what they were talking about were issues of equity and I see John there, and with issues of equity and also looking at our value system in this larger context of living with non-Indigenous peoples. Yeah. So and so I'll just move on to, and so when we look at that, what are the values held by Indigenous peoples about organ donation? Is this a way to address inequities, was the question. And why was the question considered in the first place, right? I think was really, really interesting. And it goes back to those questions of equity, which are so central. Now, this is your territory and your debate within BC, but I do want to raise the question of David Dennis and you know, and as you know, Mr. Dennis was a First Nations activist, needed a liver transplant. I probably don't have to go through this with you, and was denied placement on the list, filed a human rights complaint, and was placed on the transplant list, but died before receiving a transplant. And I know that there's people here that know more about this than I do, but why I raise this is that David Dennis taught us a lesson in our think tank, because, and it was a lesson that we already knew, I guess, but David Dennis very much drew attention to alcohol, and alcohol is a different type of conceptually different for Indigenous people, in the sense that it was actively used, and I've written about this myself, actively used as a tool of colonization. It was used to marginalize and to take land from people, to control Indigenous peoples. And then David Dennis also argued that because of the residential school system, that a way in which Indigenous people were coping was through alcohol and alcohol abuse. And so he argued, you created through colonialism the optimal conditions for this to happen. And then when we need a treatment, you're denying us that very treatment. And so he raised this issue, which is so important as we look at developing alcohol like policies, and as we look at why is it that Indigenous people will see this differently. And I have worked in addictions for many, many years, and alcohol is symbolically very, very different, thought about, and so what he did, I think, was to draw the attention to the need to think through these very complex health issues from the perspective of Indigenous peoples. And so I'll just raise that, and we can have more discussion about that later. Presumed consent, which, you know, I was at the meeting in Montreal recently, and this of course was there, and it was adopted in the province of Nova Scotia, where there are fewer Indigenous people, and I don't know the Mi'kmaq in Nova Scotia what consultation was done with them. But it's being very much considered by the province of Saskatchewan, and it's being viewed as an effective way to increase organ donation. And of course, in a presumed consent, you're presumed to have agreed to organ donation unless you opt out, or your family, you know, decides when they're in a position of decision making about you after you've passed, is that you know, they can also change that. And so presumed consent is interesting for us because there is a duty to consult with Indigenous peoples. And I would argue to anyone who is involved in advancing presumed consent to slow down and to really start to think about this somewhat differently in terms of First Nations, Métis, and Inuit peoples. And that is that to have a change like this in legislation, that you have to consult with Indigenous peoples, and there has to be, accompanying this, significant public education. We see in Saskatchewan that I don't know. So with COVID-19, vaccination hesitation is very high amongst our Indigenous peoples in Saskatchewan. And that's it's very complex why that is. But one of the reasons is this enormous amount of mistrust in the healthcare system. So if we have presumed consent legislation that is put into place without having without consulting with Indigenous leadership, and a process for that would involve public education, what we will see is, you will see, I would predict, a backlash, and that backlash would be around the mistrust of the healthcare system, people being afraid very much, I think there would be a lot of opting out for people who were in a position to opt out. I think that families, would step in at the time of death and say no. I think that because when I spoke to this was with Métis leaders about 3 or 4 years ago, and I didn't ask them about presumed consent, but I asked them about organ donation generally, and many of them talked about the fear that their organs would be procured before they were actually dead, and they talked about their value as citizenship being less, and that they feared that if somebody needed an organ, that they would not be given the same amount of medical scrutiny that they were dead than other people. So you can say, well, that's ridiculous, right? It doesn't matter whether it's ridiculous or not in your eyes. It matters whether you have the general public. So when we look at COVID-19 vaccination, that the hesitancy, we really need to understand why people are hesitant and really look at it from their point of view to try to engage them in vaccination rather than, saying it's ridiculous, right? So these are very complex issues, again, of which I hope that we can have discussion. So what can be learned is the inclusion of First Nations, Métis, and Inuit into ODT system decision-making. We need more, I think generally in all of the tables, I mean, I haven't sat at any tables, but where I've been and where I've listened, I really feel that northern, remote, and rural areas particularly need more attention. We had one family who had to give their child up for adoption because this was years ago, but she needed a heart transplant. And, Indigenous people living in the north are, I mean, in this case, the family had to decide what was best for the child, and what was best was for her to stay in Edmonton and be adopted by a family because they couldn't move their whole family to Edmonton and relocate. They were staying in the far north, and it was just a horrible, terrible story of a decision none of us would ever want to be in. So we need to look at that. I think virtual care and what is the role of virtual care in this context is really important. And we need patient-driven research that examines the experience of Indigenous people and distinctions-based approaches to research and policy development. And so that's my presentation. And we have a Facebook and a web page. You can always reach out to me, and Dr. Gill has been very much involved with our think tank. And so, so thank you very much.
Thank you, Carolyn. That was excellent. Can people hear me? Yes, you can hear me, right? And maybe if you stop sharing the screen.
Oh yeah. Sorry,
That's okay.
I am not the tech person that.
You just go up to the top where it says stop sharing.
Oh, where am I? Oh, yeah.
Yeah. Should be. There we go. There we go. Hi. So John's made it on, and there are over 50 people from around the province on the call. So I'm going to invite various people to put their questions in the Q&A if you can, and we'll do them. That's often a little bit more efficient. And John, I don't know if you want to start with some questions.
I want to say 2 things. So first of all, good morning, Carolyn. Thank you for doing this. The first thing I want to say about my experience with my participation in the think tank is that I get so much out of it in the sense that the group really doesn't care if you're a non-expert. And to me, it's almost a safe place for me to learn and to share my ignorance. And not feel judged, and not feel like I have to tiptoe around and say things that are important. So I think there's a real truth and honesty in the group. And the biggest thing that I feel as a health professional is that sometimes I don't want to say the wrong thing, or I don't want to offend by saying that I don't know. But what's really genuine, and I think this is one of the things that I want to share with all my colleagues, is that it really isn't about getting it right. It really is about the genuine effort to understand and to engage. And that to me has been, really honestly, truly a gift for me in the sense that we don't know everything on our side of the ledger, and just the willingness to appreciate that. I wanted to get to one topic, because you brought up some very controversial topics, which I think need discussion and honest dialogue. The one issue about the specific registry issue, the one thing that I think is true is the perception that on the living donation side, that there is an unwillingness to come forward and donate. In fact, in my experience, there is a higher level of excluding people as potential living donors for medical reasons, whether they be pre-diabetes, pre-hypertension. So there's medical exclusions for people who come forward as living donors, and those are more frequently encountered in Indigenous potential living donors. And I think that from my perspective, one of the real issues is a fairness piece in terms of trying to get at that barrier. I think it's an important issue that's received relatively little discussion. But I think that number one, making it clear that people are coming forward as living donors, but they do face bigger barriers, whether they be socioeconomic or actually overt health considerations that would exclude them. We need to somehow reconcile that as we think about, making the system more fair for everybody.
Yeah, absolutely. In the work that we've done with living donors, the barriers are significant, and just to get the workups that people need, and the socioeconomic piece of that, and of course there's the employment piece as well, right? So there's a lot of talk about bigger organizations and corporations, right, which is really, really good, of having them support people who want to be living donors. But for many of our Indigenous peoples, they're not in geographical locations where there's most of them are employed by smaller, like band councils, or they're employed by sometimes the health authority, right? And so, so we need to have the governments get on board, and but it's not so easy for people to take time off. And then when you look at, so we have non-insured health benefits, which will support, I think it will support some living donor with transportation and that, but for Métis people and non-status, there's not a lot of support, and oftentimes, you're the sole breadwinner in the family, so yeah, so there's all kinds of challenges that people face, and we just don't have enough data. We don't have enough information to know.
Yeah, no, that's a great point. And I think that, as you said, virtual care and other things, and simplifying workup. I mean, barriers of socioeconomic aside, just lowering the barriers for how one comes forward, how one gets information, and how one can get workup done rural and remotely without coming to the city, so to speak, is one of the things I know that various people are working on. There is a question in the chat.
Yeah, there's a question in the chat, but I'll come back to my comment. This is from Dr. Copeland. I'll read it out, Mike, but you're welcome to pitch in if you want. So thank you for a great presentation. I appreciate the think tank model. In a province like BC with so many different First Nations, do you feel this model of engagement would work? So Mike's getting at the diversity of the community, how to balance the varied voices and priorities of different subgroups without inadvertently missing certain voices. Carolyn?
Yeah, I mean, that's always a challenge, and even within our group, having Métis and First Nations, but then there's also male, female, and age groups, and so in any context like this, you're dealing with multiple challenges of voice, and making sure that you have people there that are representative. We tried to have a gender balance. We tried to have a balance between First Nations and Métis. But within Saskatchewan, we have very diverse First Nations, for instance. So if you look at the far north in Saskatchewan, a lot of people who are First Nations Dene are very traditional people, but they're Catholics. They're very Christian, and so when we talk about different things around spirituality and that's a huge factor for people. The South is very different, right? So a lot of people are very much, they don't identify as Christian, but very much embedded in their Indigenous, their First Nations cultures. And so it is really difficult. And the way that we approached it was partly by being able to bring people in from the North and that lived experience of having people talk about their lived experience. And so that the think tank, while it has a core group, it's open to people, it's fluid, so people can move in and out of it. And we have seen that work very effectively. But you're right, it is really, really difficult. But, again, encouraging, like what we hope is that we will encourage more of this type of modeling, but it is expensive. That's the other thing. So each of our meetings probably each month costs about $5,000 when we are in person. So if you're trying to, online has helped, but some of our people are reluctant. They don't like the online format. And so it's really a bit of a dance. But we feel that we can make a contribution. And one of the ways is through language, is the public health messaging, is make sure that things are translated into Indigenous languages, using the Indigenous radio stations and other types of knowledge translation, mobilization opportunities that could be inclusive. But it's a really good question about how to kind of balance that.
Can I also ask you to, the notion of time, and that that a lot of this takes a lot more time than often the healthcare system wants or physicians want to do. And I've been very humbled with the need to slow down in order to get somewhere different. And perhaps you can speak a little bit about that.
Yeah. So I have the great privilege of turning 60 next month. And so when you're 60, I have learned that you've seen now a few decades of life, and that change, societal change, is slow, right? And so it's slow, but yet there is this sense of urgency that drives me a little bit crazy, because when we grew up in the middle of harvest season, my dad would, we'd get off the school bus and he'd say, let's go hunting prairie chickens. He should have been doing that, but instead we were hunting prairie chickens, and we did it as a collective. And it was time for us to be together and have those relationships, and made us stronger. And so metaphorically, I think that, we can press forward and do all the right things and be the really strong, push, and let's get it done. But by taking the time and going hunting prairie chickens, so to speak, and bringing us together and just breathing, just taking a breath as people, and taking a breath together, and just making those relationships that I don't think, and maybe it is the tortoise and the hare, fable, because I think we will get to a better place if we are more thoughtful and reflective and build those relationships. So what we have learned, like from people like Dr. Gill, and others by David Hartel, CDTRP, for all of our colleagues, what we have learned has been enormous. And it has built this collective intelligence, which we believe is growing in the province. And we can speak to the complexity of the issue in a way we couldn't 2 years ago. But not only that, I walked into the meeting in Montreal last week, or the week before. And I thought, oh, they're going to look at me and say, oh, the shit disturber who's on all these ODT, national meetings, she's here. And I was really quite apprehensive about walking into the room. And instead it was the opposite. I had colleagues, like these really amazing, important colleagues coming up to me and saying, you're helping to shape the discussion in a different way. Your group, you are engaging with us. You're open to us. And so it was totally different than what I had anticipated could happen. And it was, and that's where I think the time of taking your time to know one another and we didn't know what we were doing, right? Like we had people with lived experience. We had Dr. Moser and Dr. Kopel, but the rest of us had no background. And so we humbly, went to the ODT community and asked to learn, and then asked people to learn from us. And so the timeline is really important,
And I was also thinking about, how, whether it's decision making around dialysis, decision making around transplantation, these are often done on timelines that we probably need to rethink how long it's going to take to have discussions to build the trust and to make it a less transactional thing, for all people, but I think especially being sensitive to Indigenous trust and how we actually go about those processes.
Yeah. And we have heard stories, and again, very negative stories from some of our people in terms of their experiences. And so it raises this question of racism in the healthcare system. But I go back to the data. We actually, so we can collect stories, narratives from people with lived experience. And some of those may be the kind of stories that raise it to a level of the human rights piece, right? But really we need data. So we need to be able to look at the data and say, okay, so are Indigenous people not getting on the transplant list, or are they on the transplant list and getting dropped? I've spoke to different people who don't know why they're not on the transplant list. So they actually don't know why, or they'll say, no, I'm not going to be, but they don't know, they just don't know why. So that again, raises all kinds of questions, and it's very, very complex. And so what we don't want is, we don't want our people pitted against the healthcare system. And we don't want people afraid of Indigenous patients, so that they're afraid that they're going to do something wrong, that they're going to be seen as racist, right? And that's where policies are so important, policies and procedures of how you do things, but also that there needs to be checks and balances in all of that, right? And so in the research that the data that I've been collecting, I've asked people at different times, do you think that was racist? Do you think that the reason that, this didn't happen was and most of the time people say, I don't know. I don't know whether it was racism or whether the healthcare system, people are just tired and there's just not enough resources, and somebody dropped the ball, or somebody isn't trained enough. So it's really, really difficult for people. One of the things that is a reoccurring theme are Indigenous patients or their family advocates saying that there's a threshold of which they feel they hit at times, where they're labeled a difficult patient or they're labeled a difficult advocate. And the amount of anxiety and worry around getting to that point in their journey, where all of a sudden it flips around and they are seen to be a problem. And that's where those files, patient files, people talk about their patient files as becoming more them than they are. So that somebody looks and they see that they're difficult or problematic, and they're coming with that preconceived notion of them, right? Or that there's rumor that this is a difficult patient, and what I can say is that, it is complex, and many of the people have these long histories of dealing with systems, you know, whether that's healthcare systems, social welfare systems, you know, and they've had this long history of dealing with this. And so sometimes people can be difficult, and sometimes they can be unreasonable. But in a context where we need to have ways in which healthcare professionals are supported, so that we do have, so that there's better education, I think. You know, and I know there's some wonderful people in BC that have been doing the cultural safety training, and I know that you guys are ahead in BC probably than any other place in the country. So I want to acknowledge the Indigenous peoples and the support that they have been giving the rest of the country in this area.
Yeah, no, I think we've benefited tremendously from the willingness of both First Nations Health Authority as well as other groups, including the Métis nations, to really help us help each other, right? And I think that's been a really amazing journey for many of us. That's and you know, we're not there yet. You know, you saw the report that came about the racism in our healthcare system, which we're very much trying to address. But I think this has been a really wonderful way to start a Friday for us. No, it's wonderful to talk with you, and it's wonderful to hear your thoughts and to learn from you. There were over 55 people on the call at one point, and they come from all they're both trainees as well as physicians, as well as nurses and researchers in the system. So I think you've touched it and shared your wisdom with a lot of people. And I really thank you for that. And I hope that we continue to have ongoing conversations. So again, thank you very, very much for making the time.
Yes, thank you. This was great, and good to see you, John.
Yeah, Carolyn, thanks so much. I just to echo Adira's words, I think this is hopefully the first of multiple interactions. We have a lot to learn, and your group is organized, and I think can really help us further the progress we've made in BC. We have a number of active research. So for all those folks that are out there, we're out to make transplant in BC a level playing field for people of all walks of life, and especially for our Indigenous folks. And we're only going to get there with Carolyn's help. So thank you very much.
Yeah. Thanks, everybody.
Great. Okay. Thank you. Bye.
Yeah. Bye.